very much for having me. Can people see my PowerPoint now?
Yes.
Okay, great. Yeah. Yeah, and thank you, Chuck, for pointing out that these are all connected. They're all connected through the failure of economic analysis and the profit-driven campaign to destroy our healthcare, or at least use it as a way to make money. Okay, so 3 parts. I'll move quickly. Medicare Advantage or disadvantage, also familiar, but people may not realize how bad it's getting and how big it's getting. And then direct contracting entities. Whew, it's really, wow, these are extremely dangerous things. Okay, now let's start with where the economists who've been advising government on these issues come from and have been coming from for 30, 40 years. They expect that consumers can just protect themselves from overcharging by switching. And the key concept here is the consumer elasticity of demand, which if anybody thought about it for 2 seconds, they'd realize does not provide much protection because it depends on how much do you need the product, or can you replace it, like a sick person's going to substitute for prescribed medication, and how easy can you find another producer of the same product, which in a world of patents is not going to happen. Entry by new producers, it's not going to work. R&D costs for discovering drugs, patent protection, which has gotten longer and longer periods. And then if nothing else, just buy the competition. I mean, here we've got mergers and acquisitions by pharmaceutical companies. Hundreds of transactions every year buying up other companies so that you get a monopoly over any particular drug. So that leaves us with John Kenneth Galbraith's concept of countervailing power, a monopoly against monopolies. And economists, especially those around Obama during the Affordable Care Act, were thinking, okay, we need to empower the insurance companies or even the drugstore chains to bargain against big pharma. Well, forget the drugstore chains. Like Walgreens is owned by a drug company. CVS is owned by an insurance company. And the insurance companies don't bother fighting with the drug companies. If it gets expensive, they can just pass it through in higher premiums. And as long as all the insurance companies are paying for the same drugs, they don't worry about it. And of course, this countervailing power idea doesn't provide any protection for the uninsured. So that leaves us with government regulation, which is something that everybody else in the world has figured out. Antitrust action might be good. Price controls works very well in several European countries, or just bargaining. Here's the US compared to other countries for particular drugs. I have a grad student who has Wilson's disease. When she first got it, I guess 10, 15 years ago, the pills she takes cost $4 each. She takes 4 a day. Now they're over $200 each because the generic company, the drug's 60 years old, the generic company was bought up by something coming out of Wall Street, and they just jack up the price. Okay, diabetes is another one. I mean, it was given to the world by Frederick Banting for $1, and they've gotten control of it. And here are some more. Okay, and people die. Yeah. Okay. Now, a third of Americans, something between 20 and 35%, depending on the survey, skipped taking a pharmaceutical drug because of cost. Much worse in the United States than in, Canada has single payer, but in most provinces, it does not include drugs. So notice that Canada and Switzerland, which has the closest to a free market in insurance among the other countries, those are the 2 countries that have the highest drug prices. And most people cannot afford to take their prescriptions. And people die because they can't afford healthcare. including drugs. Okay, the VA bargains effectively. They drive down prices by 50% compared to what the rest of us pay. If we took the VA pricing, applied it to Medicare, not Medicaid, not private insurance, just if Medicare would negotiate drugs, we'd save $1.6 trillion over 10 years. That would pay for half of the Build Back Better program all by itself. Okay, why don't we do better? I just can't resist these numbers. I mean, like, God, you know, the military industrial complex, the bad guys, they're all the way at the bottom. You know, they're not the big problem anymore compared to pharmaceuticals or insurance lobbying. Okay, Medicare Advantage. This was a bad idea from the start. But, you know, there's always been a private component to Medicare. When Medicare came in, there were certain HMOs, notably Kaiser Permanente, which one of my cousins is a Kaiser doctor, or was a Kaiser doctor in California. And he thought it's gotten worse over time, but you know, he's still very proud of the way they would do medicine. Not all bad. Goes back to World War II and the Liberty ships, but Chuck and I could talk the history of that sometime. But you know, when Medicare came in, Kaiser and a few others were folded in. It's like, okay, we'll keep you, and we'll just reimburse you for the cost of health care for the elderly, and later the disabled. There were rules on how much they would get. The AAPCC, God, what is that? I have it. Adjusted average per capita cost. And then they came in and they started risk adjusting it because the average person is a lot less expensive than people with particular conditions. It got tweaked. It got tweaked again in '97. It got expanded so that private health insurance plans outside of the HMO sector could come in. They were required to cover certain things, and they were given a certain capitation, meaning a certain amount of money based on the average per capita cost of treating people with the same demographics in the county with a certain amount of risk adjustment. Risk adjustment is one of these things that sounds like a great idea until you get into the weeds, and it's really complicated, and how you do it, what you include, what assumptions you make is critical, and it's never all that great. Medicare Advantage is gaining ground, it's growing. So here's private Medicare plans. 97, there was a bit of a bump when the Gingrich-Clinton plan was approved, went down for a while, but since 2006, it's been soaring. Now 41% of Medicare population is in Medicare Advantage plans. And that share's growing. It is profitable. It is the most profitable sector of the health insurance industry. And the health insurance sector is the most profitable sector of insurance, and insurance is, after pharmaceuticals, the most profitable sector in the American economy. Bottom line, Medicare Advantage plans make a lot of money because they tweak their demographics to get a little more on average than the national average for traditional Medicare, but they hold spending down to 12% below traditional Medicare. Now, actually, I think that number I think that should be 14%, but I'd have to check. It will change over time, whatever. How do they do that? They're holding down the spending even while they're taking out profits, and they spend a lot of money on marketing. I turned 65 last year. I get all these things from, and I'm not even on, well, I am on Medicare Part A, but I still work. I still have health insurance through work. So no need to change anything. But I get bombarded with these ads for Medicare Advantage. All that marketing goes into that average spending number. So they are making very large profits, even while wasting lots of money on marketing. And they're doing it by holding down what people spend, what is the healthcare people get, and by adverse selection. Adverse selection is identify the people who are going to be very expensive and find them and get them to go away. I mean, if they die, it's okay. But the point is, get them out of your health insurance plan. If you can get the top 1%, the 1% of people who average spending $50,000, and you can get them out of your insurance plan, you will be saving 20% of your cost. I mean, that's enough, to make profits and to justify all the spending you do on research on, finding those people. Medicare Advantage enrollees have fewer inpatient stays, fewer emergency department visits than do matched traditional Medicare beneficiaries. Now, the Medicare Advantage people will say, well, that shows how good we are. Maybe, or maybe it shows how effective you are at getting people to go away who need these services. The key is the matched traditional Medicare beneficiaries. How do you match them? How do you match, somebody who has cancer with somebody who has the same gender, age, race, location, but doesn't have cancer? If you follow people who leave Medicare Advantage and go into traditional Medicare, then spend more money in traditional Medicare. People who go from traditional Medicare into Medicare Advantage spend less money. Medicare Advantage plans find ways to restrict what people do. If you're healthy, you don't even notice. If you're not healthy, you leave, and then you go to some other plan. Medicare Advantage plans with their restricted access to doctors, their narrow physician pools, are what a friend of mine called good health plans for healthy people. Medicare Advantage members are younger and healthier than traditional Medicare, and they make a lot of money. Gross profit margins on Medicare Advantage plans per covered person are twice what they are in the rest of health insurance. Okay, so if you take this slide, what do you do if you're an insurance plan? And keep in mind that the former Secretary of Health and Human Services came out of the pharmaceutical industry and the insurance industry. So what did they do? What did they come up with? They came up with these direct contracting entities on the way to value-based care. Oh, the economics profession loves the idea of value-based care. One of my professors in graduate school, Martin Feldstein, got up in front of a room once talking about how the problem with health care, problem with healthcare in this country is people don't pay for their healthcare on the margin, and physicians have an incentive to overtreat. So people go in, they ask for more healthcare than they need, and doctors give it to them because doctors are being paid for services, not for keeping people healthy. The solution was, he didn't call it value-based care, that term came in later, but the solution was something on the order of health maintenance organizations. Capitation. Give doctors a certain amount of money and tell them keep the people healthy, or else you're going to have to pay for the services they get. Traditional contracting, direct contracting entities are being started in January of 2022. So this is coming down the road in 2 months. in 10 cities, or 10 regions: Atlanta, Dallas, Houston, Los Angeles, Miami, Orlando, Philadelphia, Phoenix, San Diego, Tampa, a lot of the United States. Center for Medicare Services will hand all beneficiaries, all Medicare beneficiaries will either sign up for one of between 3 and 7 direct contracting entities, and the direct contract, or if you don't sign up, you will be assigned to one. And the direct contracting entities will be given a capitation contract at initially 98% of the risk-adjusted spending on traditional Medicare. Traditional Medicare will disappear in these places, so it's not clear what price they're going to be giving after the first year. But in the first year, they'll be given 98% of traditional Medicare risk-adjusted. It's not entirely clear how they're going to do the risk adjustment, by the way, but that's the plan. Eventually, over 5 years, it's going to drop to 95%. The direct contracting entities will function as capitated insurers. So they will get the money and they will reimburse doctors for services. They will be able to keep half of the surplus. I think that percentage is going to go down. They'll be responsible for paying losses. And the rumor is large insurers are rushing into this. I say rumor because we don't know. 2 months before this is to go into effect, we still don't know who these DCEs are going to be or who has tried to become one. CMS hasn't told anyone. Now, this begins January 1st. 100% of non-Medicare Advantage beneficiaries in these regions will have to sign up. There would be no longer any fee for service. You will either choose a DCE or you'll be assigned. Physicians can have the option of aligning with the DCE. Aligning meaning you will only take patients from that DCE. Or you will have to deal with as many as 7 separate DCEs to which your patients have been assigned. The DCEs will be insurers. Their incentive to engage in adverse selection, everything we've talked about. Also, the DCEs will have an incentive to engage in adverse selection of physicians. If you overtreat, the DCE will have the option of getting rid of you. Competition, there'll be no more than 7 in a region, as few as 3. What competition will there be? I mean, after all, we don't even know who they are. People are going to be signing up very soon, or they'll be assigned. If you're assigned, no competition. They'll be adding a layer of bureaucracy, marketing, profit. Will it lead to efficiency? Maybe it would be nice if it did. But I think if you have to choose between the hard work of practicing better medicine, of keeping people healthy, or the easy work of getting rid of sick people, adverse selection will win every time. And of course, this is what the economists have been recommending. I mean, economists have been, like I said, they've been disdainfully dismissive of what doctors do. Dartmouth studies, whatever. Okay. CMS has not published the applications to be a DCE. Why not? What does that tell you about the role of competition and how much they value competition and choice? They're not even telling people or doctors who the DCEs will be or what their practices will be, but they'll be assigning people. Okay. Like I said, that is coming down the pike. It's happening very soon. It's a Trump administration initiative that the Biden administration and Becerra haven't done anything about. I understand that there are legal obstacles because these contracts have been publicized and all. I don't know. I don't know the politics of it. But what I do know is that there is a ton of money to be made from this. Medicare fee-for-service provides health care for a large part of the total American health economy. And it's obviously an area that private health insurance wants to get into. Okay, that's 20 minutes.